Okay.
Yes.
All right. And we'll go back here.
Got it.
Okay. Oh, it just did the same thing again, didn't it? I don't know why it's doing that. Okay, we good?
You
Good.
are.
All right, very
Perfect.
good. Okay, so it is recorded. So in any case, Linda, I'm going to turn it over to you if you want to tell us what you're doing now.
Well, just for the recording, the first speaker you just heard is my colleague, Mary Ben-Benick. She and I have taught together for maybe 20 years. I couldn't count, at the University of Minnesota. We both were devoted to practice and have included that in our day. And in fact, Mary, I think you worked in the clinic this afternoon and
I did.
have some fresh stories. I am retired, but I'm a tired grandmother of 5 little girls who were all born very recently, not in the same family, 3 families, but I'm practicing pediatrics, which was my field, in a very personal way. I live in a seniors high rise where I've been the COVID quasi expert, if anybody is, for 100 and some people. And I've had continuing challenges. And if anything, growing humility. And I know that that will be something that is the theme of our talk. Diversity, equity, inclusion is what DEI stands for. And Marie Manthe just mentioned a 1934 article by Eleanor Roosevelt, which she said is entitled, "What Does the Public Expect of Nursing?" Well, I think that will also be our theme. What does the public expect of us in 2023? We last talked about this with your group in 2015. It's a very, very different world. Back to you, Mary B.
All right, thank you. So our objectives for this evening is we're going to revisit cultural humility. If some of you are not as familiar with that term, we'll talk about that. We also want to examine barriers to implementing cultural humility. And then we'll explore how cultural humility can improve patient care, safety, and experience. And we're going to be doing that through some engagement. So we'd like to get into small breakout rooms. We'll have a couple of times where we want you to discuss things, to kind of mull it over and see what you're thinking. We'll also review the new AA, the American Association of Colleges of Nursing Essentials, relative to diversity, equity, and inclusion. That is a pretty predominant theme this time around, and we are trying to incorporate that certainly into education, but it also has ramifications for healthcare delivery and for our institutions. So we hope to weave that in a little bit and see how cultural humility fits with that. And then lastly, we're going to discuss how cultural humility might support strategies to enhance DEI within the nursing profession and within healthcare systems. And Linda, I will roll it back over to you.
Cultural humility is a term that came out of California from a couple of scholars. And the first author was Chervillon. At this moment, I've forgotten the second, maybe Mary remembers. These 2 scholars were very interested and devoted to their clinical agencies, putting something besides this cliche of competency into practice. And so cultural humility has resonated with me because it's about yourself, critiquing yourself, constantly living with an attitude of humility. And you'd think that, well, sure, of course we do, but it goes beyond that to acknowledge the beliefs and values of others, the uniqueness, and then to do a mutually beneficial care model. One of you, while we were chatting, talked about a community partnership in public health and returning to the community. We all think we do that, but we must do it better. So as examining our assumptions, suspending judgment. Don't judge, my son always says. And then he says, Mom, don't judge. Ask questions. Don't be afraid to ask. All right, Mary.
One thing I'd like to add there, if you really dig into the cultural humility literature, it also talks about the recognition of power dynamics, and it fits so nicely with DEI because it really encourages us to try to fix those power imbalances by bringing about partnerships with people and groups. So there's some institutional accountability in cultural humility as well. So there are certainly challenges to cultural humility. I think we could all agree in the last few years with political, societal, COVID, there's been all kinds of challenges to understanding and appreciating others. But we know that there is the existence of stereotypes and bias. This is also not only individual, but societal as well. So cultural humility asks us to always examine those biases, whether recognized or implicit, and to think about that. There are time constraints within clinical settings, whether it's hospital or an ambulatory setting. There's always other demands on time, and sometimes that can get in the way of really forging true relationships, really taking the time to understand someone else and their viewpoints and perspectives. There are institutional policies and procedures. There are political and societal events that occur that may pose dramatic challenges to cultural humility. There's educational inadequacies, a lack of role model in education as well. And I think that as a profession, that's certainly something that we're going to be talking about a little bit later, but things that we can work on to reduce some of that and enhance our cultural humility. Limited shared language abilities is a notoriously important aspect of cultural humility. It's that connection, that learning to listen and be able to communicate with another. And then a failure to understand and appreciate cultures different from our own. We've seen a lot of division in the last few years in this country, in cities, in neighborhoods, in families, as it may be. And so now more than ever, we really need to get the message out for cultural humility and to step back and just pause and think about things. And then there's a lack of cultural role models, as I mentioned. And then the other thing that Linda pointed out, this is a lifelong process. It's not a one and done where you do a deep dive into cultural humility. It means that every day you step back and you reflect and you think and you move forward and you find a way to make an engagement or a partnership with another individual. Linda?
This slide shows some of the language around cultural humility and contrasts it with a long time term particularly in the nursing education standards of cultural competence. And there were even levels of cultural competence in the old literature, which some of you might call awareness, and then finally you reach the peak of this competence. Well, I guess we're skeptics about that cultural competence, and we dropped that language personally, Mary and I, quite a long time ago, taking instead the self-reflection and the mutually beneficial approach that I talked about before. Setting goals for ourselves through collaborative learning and self-reflection. What is that goal? I heard somebody say they wanted to just walk in a neighborhood that they were afraid of. Well, now that's a thought, but that there's no end result. We're not going to get there. We can't suddenly think that all this searching that we've done, the reading we've done, the groups we might have attended have achieved the result of competence. Instead, we hope that we will give you some thought about the humility and then you gaining from these relationships and appreciating the other parts of the world that maybe we haven't been as comfortable in.
So how do you practice cultural humility? Linda mentioned it already. Ask yourself questions. Why do I think that? Why am I behaving that way? I can tell you an example a few years ago I like to think of myself as fairly open. I was riding home from the U on my bike on a bike trail that's sort of sunken down low, and I saw a whole group of minority young men walking toward me. I was on my bike. It was about 6:30 at night. I felt a little vulnerable, and I actually got off the bike trail, and then I was horrified that I'd done that. So I got back on the bike trail, and what I learned as I got closer is that they were teaching someone how to ride a bike. And I sat there all the way home thinking, where did that come from? And it's just like these biases creep up. And so that's why I say you always have to question, why am I thinking that? What's motivating me here? And that's a big piece of it. Every time you walk into a clinical setting or you lead a meeting in your institution, those are questions. What's underneath here? You have to be curious too. Part of cultural humility is learning about other perspectives, other cultures, other values and beliefs. So ask the questions, integrate, share learned experiences. try to understand other people's customs, etc. That's a way to start building bridges and moving forward. Keep an eye out for unconscious bias, partner with the other person. I think we've talked a lot about engagement. You never, you have to get over the notion with cultural humility that you can do it all yourself or that you've got all the answers, because that's some of the beauty of cultural humility is you don't have all the answers, and you can learn new and better things and better ways to do things when people partner and share their lived experiences and their other beliefs or lenses they might see something through. One of the greatest tools we as nurses have is practicing active listening. Sometimes when I'm collecting a history, you get the most out of just listening to what your patient has to say and reading between the lines. And if you never take that active listening, you're going to miss things. So I encourage people to slow down and do that. You also do want to supplement with cultural knowledge. There is information out there about different cultures, different religions that might not be your own. It's useful to have some of that. You have to, there's a fine line between knowing things and creating stereotypes, but it can be informative, and it may even promote you or motivate you to ask some questions if you don't understand. And then, of course, treat individuals with respect and kindness, and then partner with stakeholders. And that means all the stakeholders. It's not just you and the patient, but maybe it's the family, the community, maybe it's the institution in which you work. So that's the way that we push cultural humility forward. And I guess as we move through this talk and we go along, I'd like you to think about your own ways that you might practice cultural humility in the settings in which you live and work.
Let's talk about bias. Let's think about bias. I'm going to give you an example of mine that isn't related to skin color. And it happens to be piercing of the nose or putting rings in your ears. Now, I can never imagine doing that to myself, but I know that when I see it, there's something in my mind that pops up that is a bias. So it's a natural human reaction to certain things that we are personally uncomfortable with, never experienced before. And we can be curious. We can also judge. Maybe we judge and we're curious. Suspending the judgment and holding the curiosity might help us. So there's something called the Harvard Implicit Bias Project. I would imagine a lot of you have done this. If you have not, we would really like to encourage you to do that. And you will be surprised, perhaps I have been, Mary has, at kind of this unconscious reaction that you will have. And they measure it for you and give you feedback. So what does that do when I walk in a room and I find somebody with a nose piercing or some other kind of thing I can never imagine doing to my body parts? In healthcare, they expect us to suspend that bias, to treat that person with respect. And that's where the humility comes in. So it does interface with humility if we can hold on to that thought, I will suspend my judgment and recognize, even if it's not in that moment, reflect back and think, oh my gosh, I said that because it triggered a bias that I have. Mary?
Yeah, I think that's the part where we were going to break out into small groups, Kathy. And so I'm going to stop my share. I'll paste these questions into the chat, and then I think Kathy will put us in breakout groups. So there are 4 questions here. There's a definition of what bias is. It's that sort of unreasoned or unfair distortion. And then we have 4 questions. Is bias a natural human reaction? When does bias become prejudice? How does bias lead to inequities in healthcare or health outcomes? And how does bias interface with cultural humility? So I'm going to stop my share. And it looks like there are some chat questions. Okay, so I'm going to paste these in. Get out of here again. And Kathy, do you want me?
Yeah, I think you
It looks like I can, so I'll
Yeah.
just assign automatically, and we'll do, how many people are here? 28. So should we do 4 breakout rooms? That would be 7 in each. Okay. And then I'm going to try to get that. Okay. All right. So when you get a notice to join, you can just join the room you've been assigned to. What is this happening?
Well, hello there.
Hello.
Here we are, the same group. We're the only ones that broke out, I think.
I think we
Hopefully-
have to come back soon though, because I just remember seeing that it seems like at least over a minute ago, a 2-minute a warning that we'd be
Right.
back. So,
I just got a book from the History Museum about the development of racism in the Twin Cities. And flipping through it, I recognized so much of it from when I was a kid.
Yeah.
I'm
Where'd
anxious.
you grow up, Martha? What part of the Twin Cities?
St. Luke's Parish, Summit, Lexington.
sure.
Okay, St. Paul.
Yeah.
You know,
Blacks. Okay.
huh,
This has been a really interesting read.
Oh, I bet Heather, that would be really interesting.
Was she in the military?
Yes.
Yes. Yes. She spoke at one of our conferences.
I was at the official Black Catholic Church in St. Paul. So designated
That's right.
diocese, I guess.
That was right in our neighborhood.
Which church is that? What parish is that?
St. Peter Claver.
Oh, okay.
And it's about 6 blocks away from St. Luke's.
Interesting. It doesn't have any colored glass. It doesn't have any colored windows. They're just plain glass windows, and I just wondered about that.
Well, welcome back, everyone. I think, no, we might be missing a few.
One of our people had to jump off and go take a kid to dancing. So
But
you
she's
may
coming
have
back by
Okay.
phone.
lost a few, yeah.
I'm not seeing Linda, though.
Oh,
Let's see. if I-
Not seeing Roberta.
Hi, Martha Shekel. 2 Marthas at one meeting. That's pretty unusual.
Yeah,
I don't know what happened to Linda Key here in middle. No.
I was in her group. I'm back. I don't know where she went.
Oh, she was in the waiting room, it looked like.
Oh,
All right. Oh, there you are. I was worried we lost you somewhere, Linda.
I think you were worried.
It took me a bit to find the little thing down below.
Okay. Well, I hope you had some good conversations. Would anyone like to share? We had some excellent points made in ours. I'm wondering if anyone from the groups would like to share. I hope you could see the questions. I put them in the chat, but then I realized once you go in the breakout room, you can't see the chat.
yeah.
So it was really around bias and sort of bias versus stereotypes, prejudice, and then how it can lead to inequities in healthcare and health outcomes, and what cultural humility might be able to do in response to bias and eliminating bias. Does anyone have any thoughts, anything they'd like to bring to the whole group before we move on? I feel like I'm teaching again. I'm not going to call on anyone though, so we'll just move forward. I'll bring the screen back up.
Well, if I may quickly say, I think we did agree that bias is something that is common in everyone. So I can say that it is innate. We just need to be pay attention to it. We need to be aware that we all do have bias.
Yeah,
Yeah, I think that's a really good point. I would agree. We also had some examples of how bias could lead to inequities in healthcare and health outcomes. I think, David, you gave a pretty good example of that. Anyone from other groups, anything you came up with?
well, we differentiate a little bit the prejudice versus bias.
Mhm.
The prejudice being judging, prejudging even.
Yeah,
Make it right or wrong, better, worse, that kind of thing. The bias is sort of normal, I think, but the judgment is when the problem comes in.
mhm. Yeah, we also brought up in our group, it's something you have to keep working on, and probably even before you enter into our profession to some extent. and then it becomes lifelong. Yeah. All right, I am going to share my screen again. Okay, well, we went back to the beginning. I have no idea why.
Click, click, click.
Okay, so in your discussion groups, you probably talked about different areas of bias. I know some of it came out in our group. These are some things you can find in the literature where we definitely see bias. Age, disability, we've talked about some of these already. Education, language, ethnicity, health status, disease or diagnosis. In our group, there was an example of sickle cell disease and the very real pain that comes with that and the need for opioids. So sometimes that's bias that come out. I talked a little bit about working with people in addiction recovery and their hesitancy for vaccines and not wanting to put those in their body. And I always have trouble with that. And I have to just regroup myself and think, okay, they're coming from a different perspective on this. And then social contact, insurance status, obesity, race. One of the things I do want to mention obesity because it comes up and again, it's really a prominent bias in healthcare and it's overlooked. And that's something that it really can interfere with an interaction with people. So that's another good thing to bring out there that we don't always think about. Race, of course, is an area for bias, socioeconomic status, sexual orientation, skin tone, and substance use, all of these things. And then I think others have brought examples, but think about these as you move forward. If there are things you could add to this list, things you see in your everyday life or in your place of work and in institutions as another means of creating bias. Okay.
We have so much language about culture in our profession. We have the language, and on this slide are some terms that are used by the federal government, particularly the cultural health national standards, and those are from Health and Human Services, and this is today's version. Provide effective, equitable, understandable, respectful, quality care. Well, we've all tried to do that for our careers. Preferred languages. And maybe some of you have experienced working on the telephone with telephone interpreters. I mean, we have tried so hard to do this. And having interpreters come when you have 50 languages in your hospital is a huge administrative challenge. Health literacy, both in other languages and in levels of comprehension, and using alternative communication, we've tried. And yet we know that we are lacking for many, many people whose health is affected by not meeting these standards. These are the goals. And in governance, leadership, and workforce, communication, engagement. So as somebody mentioned early in our chat, engaging and continuously improving the accountability with standards and goals measured by the people who are the recipients of care, so that every encounter is actually appropriate for that situation. That's our broad goal. And the feds, of course, have given us these standards. And now we're going to move to what nursing has done to try to address these on the next slide.
Yeah, and I always look at this as really the nursing process, because it is about planning, it's about implementing, it's about evaluating. And I think that in our everyday work, sometimes we forget that every time we're working with a patient or we're in a meeting, we're doing those things. And so this just reiterates that. This particular website actually has 3 modules available, so people can work through those modules to dig a little bit deeper into the cultural national health standards. I thought they were pretty good. The principles embody pretty much what we're talking about here. But this year, the American Association, or I guess in 2021, they've just come out now to be implemented, but the AACN came up with the new essentials, and this is for undergrad education and graduate level education. And they even talk about masters in DNP to some extent. But what you see here is they really have an emphasis now on diversity, equity, and inclusion or inclusivity. And so what we see here is that we have definitions we gave to you, but know that in every nursing school across the country, we're trying to map our curriculum to match these three things. And so it really is emphasized. It is an essential part of nursing. And we are seeing that we are in a really diverse time period here, and we're going to start giving you some examples of different ways our world is changing and the different ways nursing is changing, and sort of motivate us into looking forward to moving into better diversity, inclusivity, and equity. So this is there. It's a huge document. If you have any time and interest, you can certainly look through that, as it is available online. But I was pleased to see that this had such a prominent place in the new essentials. I think that's a step forward. Okay, so the facts. We're talking first about the nursing profession. And if you look at the Brookings Institute in 2020, they identified that more than 40% of the US population now identify as people of color, and minority populations will become the majority by 2045. So that tells us that this is our future. This is the demographics of our country. The National Council State Boards of Nursing in 2020 identified that nurses from minority backgrounds represent 19.4% of the registered nurse workforce. So what this shows us is there's quite a gap in the number of individuals we are preparing to be nurses, those practicing, and what our population will be. And so one of the things we hear about in DEI is to get people of other ethnicities, et cetera, to fill our workforce. And so that is a goal for nursing. It's time for us to step up and really look at recruitment, support, maintenance, promotion, and those sorts of things. The National Sample Survey of Registered Nurses, this is a little older, but I still thought it was interesting. They identified that as far back as 2008, RNs from minority backgrounds are more likely than their white counterparts to pursue baccalaureate and higher degrees in nursing. And again, the AACN report in 2021-2022 shows that minority students make up 40.8% of entry-level baccalaureate, 38.9% of MS, 35% research focused, and 38.9% DNP. So I was encouraged by this. I feel like we are at least trying to move forward in that era or in that area. So that's kind of the facts about where we're at with the nursing profession. And I will let Linda talk about the healthcare system.
I appreciate Heather and Nikki adding something that DEI is also then combined with a new perception of belonging, and that they have recently heard that in the workforce. Thank you for putting that in the chat and moving our discussion even further. More sobering and stopping you in your tracks sometimes when you see these statistics that are in front of you, and those are that the non-white patients receive fewer cardiovascular interventions, renal transplants, the breast cancer mortality 40% higher, prostate cancer, and the bias studies are listed here. And here's one close to me because my daughters and daughters-in-law experienced preeclampsia. And this has been replicated several times recently. Black women 3 times more likely to die in pregnancy than white women. Very sobering and prejudging. Some of the people's presentation in the ER is behind some of those questions, some of those stories. And it's hard to accept that that is going on in this day and age. Back to Mary.
Okay, so we're going to go back to our breakout rooms. You can take a look at these questions. What does diversity mean in healthcare, in the nursing profession? What does inclusion represent in healthcare, in institutions in the nursing profession? And what is equity in healthcare? What is needed to create equitable healthcare systems? And then how are we doing? And you can give yourself a report card. You can give the nursing profession, the healthcare institutions, or academic institutions. So again, I will copy these and I'll paste them in the chat, but you may want to look at them quickly. Whoops.
How's our time going?
Yeah, I don't know that. I can't see.
I've got 7:55.
Oh, Kathy.
Kathy,
We may want to could we just do this discussion as a large
Yes.
group?
the full group.
Most definitely.
Yeah.
our ending is really just some strategies, but hopefully we'll come up with some of those in our group as well. So I will stop the share and then we can just open it if people want to take a look at those questions. I'll paste them in the chat.
How are we doing? Several of you have had presentations today from the sound of it even. Do you feel like there's progress?
I think that there's more attention on it, but especially when you look at the Black maternal data, it doesn't feel like there's been any movement from historical to current. So I'd really like to see some very quick movement in that. And I think that's going to be one of the key indicators going forward if we're making any progress.
The outcome measures.
Yeah, and I would
Yeah.
add to that, when Linda and I were looking, we found these statistics that showed that women of color who came from other countries had better outcomes than people who'd lived here a long time. And we've known this for years. And I was appalled to see that that was still the case, that we really are doing something wrong.
It's heartbreaking. Yeah, it really is.
Yeah.
In our discussion group, Marshall brought up the fact that in some ways our electronic health records sort of are biased. They were designed by, for the most part, white straight men. And the fact that he was mentioning someone who had spoken. Marshall, are you on? You should describe it, but describe the woman who spoke and about how she always looks at her health record. But I'll defer to you, Marshall, but I just want to say, I think that people of color are much more likely to be classified as aggressive versus assertive, non-compliant versus that they have questions about their care. And I think Marshall's story really hit that home.
Yeah, so it was a presentation by Dr. Valerie Garr at the University of Iowa in their College of Nursing. And it was very interesting because she shared that, because it was about implicit bias in healthcare. And it was very interesting because she shared that, whenever she was in the hospital, she would request to review her medical records, which for those who don't know is quite cumbersome, is quite a legal a challenge to do legally, but you can do it. You are entitled to that. And what she found is that how she is depicted in like nurses' notes and physician notes is quite awful, and far from the reality, the way that she perceived it, and talking what Dr. Chesney has said, aggressive, non-compliant, stubborn, think of any negative adjectives, you could throw them in there. And that partly has to do with our documentation. And I think in order to catapult modern nursing care and modern healthcare into a culturally humble state, we have to revise antiquated methods at its core within our information system. And we talk about bias. My bias is information systems because that's what I study. But to recognize that, something that pulses so intrinsically within the system is corrupt, it only spews out to the exterior.
I also just want to share a recent experience. I think that we talk a lot about DEI or DEIB with regard to race. But I do think, as you said, Mary, obesity is an issue. I also will say there's a lot of age discrimination within healthcare. And I speak from the experience a year ago at this time, having a knee replacement surgery. And I was in a shared room with someone who was probably about 10 years older than I was, but both of us were constantly referred to by the nurse's aide as my dear, dearie, these very patronizing, kind of pat you on the head, you're just an old lady kind of thing, and in a very pejorative manner, to the point where I was just disgusted by the time, and I was there 24 hours. And I think 3/4 of the people I dealt with, that was how they, addressed me, addressed the other woman in the room. Even after repeated times of asking to just, you feel free to call me by my name, Mary, kind of thing. And so I think there's a lot of age about someone's older and suddenly it's this assumption that they're feeble-minded. They can be talked down to, they have to be told what to do. So I'd like to see a look at age in addition, as we look at different ways that people are diverse, and look about how our hospital culture can really pick up kind of some real bad vibes against aging.
Mhm.
When I mentored new nurses, and when I taught nurses who were in the emergency room or even on the floor, listening to report, I would always tell them, ignore what is said in report, except for the data that you're getting, and go in and do your own assessment, because many times the report itself was so prejudicial to the patient. It's no wonder you were walking in with feeling badly before you even went in the room, like, do I really even want to go in there? Many times. Then I'd have students actually ask me that. I don't really want to go in there. And I say, ignore the report. Sometimes our own transmission, that's the point I want to make, our own transmissions between each other is a transmission of that bias that we hold, and we want to get support from other people within nursing for the same thing, and yet it is a continuation, and it can be damaging to the patient themselves on a shift by shift basis.
Mhm.
Another one that we haven't really covered with bias, and it reminds me of when my daughter-in-law was a nursing assistant at the community hospital, and she had I think it was a female going through change to be male or vice versa. Can't remember what it was, but they wanted to be called what they were becoming. And so she respected that, but she said that when others would go in, other staff would go in, they would call them the opposite, just to and then Morton would go back in, she would just cry, and say how hard it is for her, going through that. And then it was like the staff weren't honoring her wishes at all. So that was the eye-opening too.
Yeah. Yeah, I think, I don't know, Kathy, how much time we have or when this ends, but I think you've raised great points here. I hope that you can carry this back to wherever you're working, living, et cetera, and figure out what strategies you can use to move forward and embody that cultural humility in some of these emphasis we're having and these initiatives on diversity, equity, inclusion, because like someone mentioned, we do a lot of talking, but we're not seeing the change. And so the only way we're going to do that is shake it up a little bit and start to bring in different and new ideas that are not what we've been trying over and over again, I guess.
Being the role model that you wish you had, or encouraging someone to practice speaking about a subject with you because you won't judge them, reading a lot, going in a neighborhood you're not comfortable with. And there are so many books that I can't read fast enough or deep enough, and it's humbling. I leave you with that thought of the lifelong commitment to humility.
Kathy, can we send you titles and you could include them in the next newsletter, perhaps?
Absolutely, I would love that.
Thanks.
I put together a list of some websites and field trips that you could take just in our community that I have enjoyed. And I think Kathy's going to send those out as well.
And they're actually on the agenda, at the end of the agenda.
There we
So,
go.
but I can send them out again also. I'll put it in the newsletter.
I also really liked Heather, I think it was you who had the community partnerships. I came in just as you were talking about that, but that's the partnership. And if you get in at the ground level and incorporate the people while you're trying to do things, you're just going to be more successful. So I think as nurses, we could do that, move into population health a little bit more in communities and engage those people in the communities. That's what I would hope for all of us.
Thank you for your comments.
Yes, thank you. It was a pleasure.
Thank you both, Mary and Linda. This was a wonderful evening, and we're so appreciative of your time and your enthusiasm for this. And we'll be asking you to do it again in a few years.
I might age out.
We'll catch you before then.
Okay.
Okay, thank you, everyone.
Thank you,
everyone. Thanks for
Bye-bye.
your presentation.
Bye-bye.
Thank you.
Kathy, I think I'm still the host. Do you want me to end the meeting for all or what?
Yes,
Can I say something? Sorry, I just wanted to say something really quick. My video was off. I just wanted to say your presentation brought me to like tears. It was so educational, but just so beautifully put. When you guys use the example of riding your bike and going on the opposite side, like that is my family, that I have endured that encounter where
I
people
know, and that's what it was. It was horrifying to me that I did that.
But the fact that you recognize that and the information you put out, it was absolutely beautiful. So thank you for this. This is.
Oh, thank you.
I've been dealing lately at work. It seems more and more patients I get are older and they're very in their ways and I have been called a lot of derogatory names. So you just get like battered down sometimes.
I'm so sorry.
No, it's okay. It's experience. You learn and you grow. But just being able to see someone who is not Black or as a white woman who is trying to educate people through experience and facts is absolutely beautiful. So thank you for that.
Well, thank you. Really appreciate it. I'm so glad you were a part of it.
Yeah, you guys have a wonderful night. Bye-bye.
Thanks. You too.
Thanks, Nicole. See you soon.
All right. Well, thank you, Kathy. It was lovely to see you.
Thank you for letting me just make you the host. It was so much easier.
It was fine. And I've never had such trouble putting my PowerPoint up. I do teaching every day. And I'm like, what the heck? Anyway.
I started out so poorly that I signed into a meeting I had earlier tonight and people couldn't get in. So I think the little Zoom jinx was going on tonight.
Yeah, well, I felt so good because I got my charting done and I thought, oh, I'm here on time. And then I got caught up in emails and suddenly I see, oh my gosh, it's 6:47. So anyway, thank you. It was great to see you. Thanks for inviting us. Bye-bye.
Bye-bye.